Good evening, everyone. Kia ora koutou and talofa lava. Welcome to tonight's Goodfellow Unit Webinar on puberty, what's normal and what's not. I am Dr. Hazel Fuyava. I'm a GP in West Auckland and I work for the Goodfellow Unit. I was inspired to run a puberty webinar after having a few cases with kids brought in where I was quite stumped really in general practice without clear guidance. So I'm absolutely stoked to have Fran with us this evening to shed some light on this topic. I'll start by introducing Fran. So Fran Mouat is originally from Scotland. She trained in general paediatrics in Christchurch in the UK before moving to Melbourne to complete her advanced training in paediatric endocrinology. In 2008, Dr. Mouat returned to New Zealand and was appointed as a consultant paediatric endocrinologist and diabetologist at Starship Child Health, where she is currently the lead clinician. I will now hand over to Fran. Thanks, Fran.
Thank you, Hazel. Good evening, everyone, and thanks very much for the invitation to come along and present this evening. I'm quite excited to present on this topic because this is clearly an area where people feel they need a little bit of extra support and guidance. We do get a lot of referrals through on puberty topics. So what we're hoping to do is cover some of the common scenarios that we see and hopefully answer a few of your questions as we go along. And as Hazel will talk about later, we're actually in the process of developing a primary care health pathway on this topic, which hopefully will be helpful to everybody too. And here's what we're going to talk about tonight. So a bit of an overview of puberty, the age ranges and the common biological changes, what the normal timing and variations are and what can influence these, what are the signs of abnormal puberty and what investigations are appropriate and when you should be seeking advice. And throughout the whole presentation, I'll be giving some case examples of common presentations and how we approach their management. So puberty, as I'm sure you're all aware, is initiated by increasing the production of luteinizing hormone. This is it here. And follicle stimulating hormone, which are produced in the pituitary gland, driven by the increasing release of GnRH from the hypothalamus. The first changes are seen between 10 and 13 years, and girls on average start puberty about 6 months earlier than boys. However, gradual increases in gonadotrophins and sex hormones actually start from 7 to 8 years. In girls, breast budding starts first, followed by pubic hair, with menarche typically between 11 and 14 years. In boys, testicular enlargement followed by pubic hair development occurs between age 9 and 14, and facial hair and voice changes typically develop between 13 and 16 years. Tanner staging in girls and boys are quite different. As we alluded to, girls start puberty a little earlier, and they do their rapid growing at an earlier stage than the boys, with their growth spurt generally starting at anywhere between 9.5 and 14.5. Their breast development can be anywhere between 8 and 13 years, and pubic hair anywhere between 8 and 14 years. And I'm sure you're all very familiar with these Tanner charts. In boys, there's about an 18-month delay from the onset of puberty to the growth spurt. And this is something that's quite important to make clear to your patients, because a lot of boys are very anxious about the slow onset of pubertal growth, worried about short stature. And so reassuring them that it's quite normal not to see that growth spurt for the first 12 to 18 months of puberty can be really helpful in reassuring them. It can vary anywhere from 10 to around 17 years, with genital development from anywhere from 11 to 17, testicular development from 10 to 18, and pubic hair development from 10 to 18. So a huge range of normal. In girls, the mean height gain in puberty is around 20 centimetres, and that's over about 3 to 3.5 years. They hit their fastest speed of growth between Tanner stage 2 and 3. And by Tanner stage 3, they're nearly halfway through, so they've probably got between 10 and 15 centimetres of growth remaining. By Tanner stage 4, maybe 5 to 10 centimetres remaining. And once they reach menarche, they do actually still have some growth potential, with girls gaining a mean height of around 5 centimetres after having their first period. In boys, the mean height gain is greater, closer to 30 centimetres. Boys are beginning puberty when their testes are around 4 mils volume, and they will have between 25 and 30 centimetres of growth left at this point. They hit their peak height velocity between Tanner stage 3 and 4, and by the time they reach Tanner stage 4, they'll have an additional 10 to 15 centimetres of growth potential remaining. Once they have reached testicular volumes of 12 mils, they've reached their peak height velocity and their potential growth is much less. There are lots of influences on pubertal timing and the discovery of common genetic variants that contribute to the wide normal variation in puberty timing, as well as other complex physiological traits, has accelerated in the last 5 to 10 years since the advent of genome-wide association studies. There's increasing evidence implicating epigenetic mechanisms in puberty timing and reproductive function. We know that there is a general secular trend to early onset of puberty, which you will all be seeing in your practices. And this is thought to be influenced by both nutrition, less chronic illness, better living conditions, as well as the genetic associations. So when do you investigate? So I think as a rule of thumb, when the timing is abnormal, so onset of puberty below 8 years or beyond 13 years in a girl, or less than 9 years or nothing beyond 14 years in a boy, or when the tempo is abnormal. So if the development is out of sequence, very rapidly progressive, or stalled or extremely slow. An assessment needs to be made to determine the cause. So we're going to go through a typical referral example. So this one, thank you for seeing 7-year-old Ella for assessment of early pubic hair development. Mum first noticed the changes 3 months ago and reports 13 pubic hairs. Now that does seem very specific, but this is actually quite a useful clue because typically pubic hair are very distinct and coarse and quite different to the normal soft vellus hair that you can get over the genitals in young children, which are not pubic hair. So what to consider here? So we want to think about our differential diagnosis, what parts of the history might be useful, what are important exam findings, what initial investigations might be appropriate, and what treatment might be an option. So for early development of pubic hair, the vast majority of these cases are something called benign premature adrenarche. This is an extremely common normal variant of puberty that occurs between the ages of 6 and 9 years in both boys and girls. It may result in an increase in growth rate and a slight advancement in bone age, but it is so common it can be considered a normal variant. The other differential diagnoses to consider are non-classical congenital adrenal hyperplasia, which is extremely rare. This is an inborn error of metabolism affecting the adrenal gland, where partial 21-hydroxylase deficiency leads to overproduction of androgens by the adrenal gland. The final group are tumours of the ovary and adrenal glands, and these are extremely rare and generally present with rapidly progressive symptoms and signs. So what history is relevant to help differentiate between these three groups of differentials? First of all, the age of onset of symptoms. Very, very young age should raise more suspicions. How rapidly do the symptoms progress? So in benign premature adrenarche, it's a very slowly progressive condition where things really don't change over a number of months. The presence of body odour, acne and axillary hair can suggest more advanced pubarche, as can the presence of other pubertal changes. Do the girls have breast development? Do the boys have testicular enlargement? Has there been a growth spurt to suggest sustained exposure to the sex hormones? Is there a family history of early development or any other medical issues that might be relevant? Is there any medication that the child or the family may be using that could have resulted in exposure to androgen? And we do have an example in our own clinic where a child was exposed to a health supplement that actually contained testosterone, resulting in some virilization. So it is important to question the family in a bit of detail about that. On examination, the most important thing is always in paediatrics is to plot their growth, and this is to look both at their actual height and their speed of growth. Speed of growth can obviously suggest sustained exposure to sex hormones. The skin, is it oily? Is there acne? Is there hirsutism? Blood pressure, and you'll all be familiar with, I'm sure, the hypertension normal ranges on the Starship guidelines. Do they have any abdominal masses, thinking about an adrenal or ovarian tumour? looking at their pubertal staging. And again, just a reminder, the Tanner staging for puberty for boys and girls, the pubic hair development, early pubic hair development, Tanner 2, progressing through to 5. Testicular volumes in boys, very important, breast development in girls, and evidence of clitoromegaly suggests more significant exposure to androgens and the need for further investigation. So that leads us on nicely to investigations and what are the appropriate screens to do in primary care. So a bone age X-ray is almost part of your examination. It is a really sensitive marker of skeletal maturity and gives an indication of the need for further investigation. An advanced bone age suggests sustained exposure to increased levels of the sex hormones. An androgen profile is also useful. And just a note here that this should always be done first thing in the morning because you're trying to catch the peak of 17 OHP. If it is done later in the morning, it's really difficult to interpret stuff. It doesn't have to be fasting, but it does need to be early in the day. So 17 OHP, DHEAS, androgen, androstenedione, and testosterone are all helpful here. Other investigations, gonadotrophins, LH and FSH, in all of the boys and in girls with breast development would be my usual practice. Interpreting the results. So benign premature adrenarche, which is by far and away the most common cause here. The bone age is almost always within 2 standard deviations of your chronological age, and your radiology team should be able to report that for you. Androgens should be normal or show a very minor increase in DHEAS only. And the LH levels should be less than 0.4, which is in the pre-pubertal range. So if you get that picture, that's very reassuring. Non-classic CAH, the bone age may well be more advanced. The 17 OHP will be elevated. And you may also see some elevations in androstenedione and testosterone. Adrenal or ovarian malignancy, again, because you've got higher and more sustained levels of sex hormones, you would expect the bone age to be significantly advanced. An elevated DHEAS more than 5 times the upper limit of normal is very suspicious of adrenal malignancy specifically. And elevated testosterones may be seen in rare androgen-secreting ovarian tumours. So what do we do about these conditions? Benign premature adrenarche, you don't actually need to do anything. This is a normal variant. There's no treatment indicated. The main things to be aware of is that some of these children do tip into early central puberty, and I do recommend a 6-monthly check just on their growth, how they're tracking, and to make sure there's no evidence of central puberty developing. And I do also counsel parents that there is a slightly increased risk of polycystic ovarian syndrome in teens who have had this normal variant of puberty. Congenital adrenal hyperplasia. Now, again, there's some controversy about whether or not these children should be treated. You can treat them with suppressive doses of hydrocortisone, but that comes with its own risk because once you suppress them with hydrocortisone, they no longer produce their own cortisol bursts and they do need stress steroids with illness. And that, of course, can be life-threatening if it's missed. So it's a bit of a discussion to have with families about the pros and cons of that. And there's still often differing opinions across the field. Malignancy, that would, depending on the origin, obviously would need surgery or chemotherapy or whichever treatment was appropriate. So who do we want to see? The benign premature adrenarches we really don't need to see. So if they have no red flags in the history, the biochemistry is reassuring, the bone age is reassuring, then we really don't need to see these in the clinic. The ones we definitely do need to see, however, are this group. So the ones where there is suspicion or concern from the history or biochemistry of either of these conditions should be referred through to see us. So that's premature puberty. So here's another scenario that we might see in the clinic. So a 6-year-old girl presenting with an isolated menstrual bleed. And this is obviously a source of huge anxiety for the family. So again, thinking about what could the differentials be? What do we need to think about in the history and examination? What investigations are appropriate as a first line and treatment options and referrals? So the most common cause is isolated premature menarche, which again is a normal variant of puberty. We know that at the beginning of puberty, small amounts of estrogen from the ovaries switch on and switch off. And if enough endometrial thickening occurs, a small bleed may occur with the switch off. This may occur several months in a row and then disappears as estrogen increases and normal puberty progresses. Central precocious puberty obviously has to be thought of, as does peripheral precocious puberty. So that's when there's estrogen production from a peripheral source, like an ovarian cyst or an activating mutation on the ovary itself caused by a condition such as McCune-Albright syndrome. Then there can be other more localized causes of the vaginal bleeding, such as trauma, accidental or non-accidental, infections, and rarely malignancy and bleeding disorders. So in the history, what parts of the history are relevant? So the timing of the symptoms, do they seem to be cyclical? Is there any other evidence of pubertal change, any breast development, any pubic hair? Has there been a growth spurt? Is there any history of trauma, history of bleeding disorders, any pain with the bleeding, any family history of early puberty? Important examination findings, again, height, growth, height, velocity. Are they appropriate height for the family? Are they very tall compared to their parents? Is the height velocity normal, suggesting sustained exposure to sex hormones? Are there any abnormalities of the skin? So this is what cafe au lait lesions look like. These are typical of McCune-Albright syndrome, which is an activating mutation which causes peripheral precocious puberty. Do they have any abdominal masses? What Tanner stage are they for breast development? And then inspection of the genitalia is really important, at least a visual examination of the external mucosa, and trying to differentiate between the estrogenized mucosa, which is pink and mucus, versus the non-estrogenized shiny red mucosa, and also looking for evidence of infection or trauma. What investigations are appropriate? And again, it will depend a little bit on the setting and the severity of the symptoms and levels of clinical concern. But things that you could check in primary care would again be a bone age x-ray looking for evidence of prolonged exposure to sex steroids, which would show us an advanced bone age. And an ultrasound of the pelvis would assess the uterine maturity, whether there's thickening of the endometrium and what the ovaries look like if there's a cyst. An MSU is a useful one just to do in your clinic room to rule out hematuria as a cause for this, and that isn't an uncommon cause. Thyroid function. Now you'll be wondering why that's popped in there. Why check thyroid function? It's not well understood, but extreme TSH elevations, which we see in profound primary hypothyroidism, do actually produce FSH-like effects on the ovaries. They give you multicystic ovaries and can give you uterine bleeding and some breast enlargements. And it's the other hypothesis that's been put out there is that high prolactin, because of chronic stimulation of TRH, enhances sensitivity of the ovaries, so that even trace amounts of circulating gonadotrophins that you get in those peripubertal years can be enough to stimulate some bleeding. Other screening I would normally do in this situation, a clotting screen, particularly thinking about von Willebrand's. And then baseline bloods. Now the lab assays have got a lot more sensitive and specific in the last few years. I know previously we haven't really been advocating checking baseline gonadotrophins, but now we really do this a lot more often. An LH less than 0.4 is a very reasonable screen for looking as to whether there's any onset of central puberty. And the estradiol assay is a lot more sensitive as well. Other investigations and referrals would really depend on the clinical situation. If you think this was a central problem, then we would be referring them an MRI. We might look at an ultrasound of the pelvis. We might refer to the paediatric surgeons if we thought there was a localized issue. And obviously for non-accidental injury to child protection services. So interpreting the results, bone age should be within 2 standard deviations of the chronological age. An LH and an estradiol should be in the prepubertal range. An ultrasound of the uterus should be tubular shaped rather than heart-shaped in a prepubertal child with a nice thin endometrium. Generally, isolated premature menarche resolves spontaneously without treatment, and treatment for pathological causes will obviously vary depending on the underlying problem. Moving on to premature thearche. Early breast development. So here's a very typical scenario for us, a 6-year-old girl presenting with breast development. So again, thinking about the differential, what in the history is important, examination findings to look for, what investigations we want to think about, and what treatment options there are. So the differential. So premature thelarch is very common, which is in the very young children. This is thelarch variant. Central precocious puberty is rarer, and peripheral precocious puberty is very rare. In the history, what age did the symptoms start? Is it unilateral or bilateral? Is it progressive? Is it waxing and waning, coming and going? Are there any other signs of puberty? Has there been a growth spurt? Are there any birthmarks? And again, examination findings, very familiar picture you've already seen. So again, this is our McCune-Albright cafe-au-lait lesions. But again, plotting growth. Are they tall for the family? Are they growing quickly? Do they have any abdominal masses? What's their Tanner stage, their pubertal stage? And again, inspecting the genitalia. Does it look red and shiny versus pink and mucus? Initial investigations, again, you can tell we don't go too far out the box with these investigations. They're all pretty similar. Bone age X-ray, looking for prolonged exposure to sex steroids. Thyroid function, because as we've said, very high TSH can stimulate the ovaries. LH-FSH estradiol, looking to see a nice low LH of less than 0.4 and an unrecordable estradiol. So who do we want to see? So the premature thelarchs who present below 3 years of age and may have even been there from 1 or 2 months of age. Typically, the breast development increases and decreases, comes and goes every few weeks. There's no growth acceleration, no bone age advancement. It generally resolves spontaneously by around 4 years of age, and you can counsel the family that it has no impact on pubertal timing or final height. So there's no real need to refer children where you're comfortable that this is the clinical scenario. However, slightly older children, thelarch variants who present between 5 and 8. In this case, the breast development persists or is progressive. There can be some increase in height velocity, and there can be a moderate advancement in bone age. We often arrange to do something called a GnRH stimulation test, which stimulates the production of LH and FSH in these children to differentiate between this and central precocious puberty. It's generally thought to be secondary to increased sensitivity of the ovaries to the prepubertal LH and FSH levels. You do need to monitor these children as it can progress to central precocious puberty. So these ones we should probably see in the clinic. And then, of course, there's true precocious puberty. So this is normal puberty resulting from activation of the hypothalamus, forming the normal sequence, but occurs abnormally early. So below the age of 8 in girls and below the age of 9 in boys. Much more common in the girls, but much less likely to have a pathological cause in the girls, interestingly. It's associated with increased height due to the premature pubertal growth spurt and an advanced bone age, usually more than 2 standard deviations. The baseline LH and estradiol are usually elevated, and this does require further investigations such as MRI of the pituitary and hypothalamus, particularly in the boys and particularly in the young girls, as they are occasionally associated with congenital abnormalities of the brain or tumours, especially in the boys. Probably the most common tumour causing this is a benign condition called hypothalamic hamartoma, which we do see relatively frequently in this group as a cause. So, treatment considerations. So why do we treat these children? Well, the first reason is because of the potential impact on final adult height, because the bones fuse too early. So yes, these children look really tall and seem to be growing really well through childhood, but once they reach the end of their puberty, they will stop growing and they may end up significantly shorter than you would expect from the family genetics, as they've lost a number of years of prepubertal growth. In addition to this, the children can experience quite a lot of emotional distress, having all these changes happening so early. It can cause behavioural problems and problems at school. But the other things to think about are potential adverse effects of the medication. Families coming in to talk about medication treatments such as Lucrin will have often been online looking at potential side effects, and there are a number of side effects associated with this. Like any medication, the list that you'll find on the MedSafe website goes on for days. But the most common things we see are pain at the injection site. This is an IM injection, so it can be a little bit uncomfortable. Local allergic reaction and systemic allergic reaction, they are very rare, but they do happen. Hair loss, and that's an interesting one. It's not uncommon to get a bit of increased hair fall when you first start on treatment, and it's speculated that that's probably something to do with the kind of rapid reduction in the estrogen levels. And then finally, there's been some relatively recent reports of associations with possible benign intracranial hypertension with this medication. Now, again, not causation as such, but something to be aware of. So we are counselling all our parents to present for assessment if the children describes dizziness, headache, or blurred vision. Now, the other topic I was just going to touch on is gynecomastia, because this is another condition that we do receive quite a number of referrals on at Starship. And I just thought it was useful just to run through how we would approach this. And again, who are the patients that really should be referred through for an opinion with us? So a typical referral would be like this. So we've got 14-year-old Ben who has gynecomastia, causing him significant social embarrassment. He's overweight, but otherwise fit, healthy boy. So what are we thinking about here? So pubertal gynecomastia is by far and away the most common cause. It is very common, affecting, depending where you read the statistics, at least 40 to 50% of adolescents. The second most common cause is fat deposition around the breast area, then substance exposure and medication, which is a bit less common, underlying health issues, again, less common, and then rarely genetic variations such as Klinefelter syndrome and intersex variations. The relevant history, so we were particularly interested in whether the onset was before or after the start of puberty. Pre-pubertal gynecomastia is much more likely to have a pathological origin. We're interested in the progression. Has it got steadily worse, rapidly worse? Is it coming and going, waxing and waning? What is the child's growth, weight gain and pubertal development been like? Are they growing quickly? Are they gaining rapidly in weight? Has the puberty stalled or is it progressing? And then asking about local symptoms, any pain, nipple discharge, suggestive of galactorrhea. We ask about exposure to prescribed medications, exposure to alcohol, amphetamines or marijuana, and also worth checking in on over-the-counter drugs and herbal supplements, those particularly containing lavender or tea tree oil. And I did, in fact, have a case of a young person who it turned out the family lived on a tea tree plantation, and we think that may well have been the underlying cause for their symptoms. Important exam findings. So again, plotting the growth. Are they growing? Are they accelerating into puberty? What's their weight looks like? What's their BMI looking like? Important to do a breast examination because you're wanting to differentiate here between fat deposits and glandular breast tissue, and obviously to exclude any masses and any lymphadenopathy. Pubertal staging and testicular examination are important to exclude tumours and to assess the testicular volumes. What we want to know is the boy in established puberty, and have his testicular volumes increased as you would expect for the stage in puberty. And then finally, an abdominal exam to assess the liver. It can be sometimes quite difficult to differentiate between glandular breast tissue and fatty breast tissue. And when in doubt, an ultrasound of the breast is actually a really, really useful tool. And it gives you a really nice, clear understanding of how much glandular tissue is present. A hormone profile can be useful if there are concerning findings. And you could do an LH, an FSH, an estradiol, testosterone, prolactin, DHEAS. If you think they might have symptoms of hyperthyroidism, thyroid function could be useful. Liver function and renal function, thinking about underlying chronic disease. A karyotype, so this is particularly thinking about a condition called Klinefelter syndrome. And these are the boys that are tall and skinny. They're going through puberty, but their testicular volumes never really get beyond about 4 mils, which is about the size of a Cadbury's mini egg if you don't have a orchidometer in your rooms. It's quite a useful one to keep in your head. Tumour markers could also be considered if there are other concerning features, if this has progressed rapidly. Tumour HCG and alpha fetoprotein would be the two most useful markers to consider. So thinking about management, who to be worried about. So gynecomastia can present as early as 10, peak age of onset though between 13 and 14. and it becomes less common as they get into their later teenage years. To diagnose true gynecomastia, there must be a palpable mass of tissue measuring at least 5 centimeters, half centimetre, sorry, in diameter. General increase in fat mass on the chest is not gynecomastia. There is an association between gynecomastia and weight increase, but it's not 100% confirmed. We know that adipose tissue is an important site of aromatization of estrogen formation, so therefore it would support the observation that as if you have a young man with higher body fat, then they are aromatizing more of their testosterone into estrogen and therefore more likely to develop gynecomastia. In most cases of pathological gynecomastia, a specific cause is actually rarely identified. So even after we do a comprehensive, careful investigation, we very actually rarely find a cause. In most cases of pubertal gynecomastia, observation and reassurance are the mainstays of treatment. It usually resolves naturally. We do recommend lifestyle interventions, so trying to lose weight, nutrition and exercise advice. Who should we see? Any prepubertal boy with gynecomastia. So we're happy to see any boy before the age of puberty with any gynecomastia, any boy with prominent mastalgia, so breast pain, because this is one area where there is pretty decent evidence for treatment, with tamoxifen quite effective here at improving the pain symptoms. And any slim boy with really prominent gynecomastia probably deserves discussion with us at the very least and some initial investigation. We don't treat very often. Tamoxifen's kind of gone out of favour because there's some concern about potential negative impacts on bone mass accrual. So we tend not to. Surgery is generally preserved for those with really significant gynecomastia that's gone on for quite some time with no resolution, particularly slimmer boys. Surgery in boys who are very overweight doesn't have great outcomes. You end up with quite a scalloped chest and the fat mass just comes back again as well. All right, so now we're going to the other end of the spectrum. We've talked about early puberty. Now we're going to talk about delayed puberty, which is probably the second most common group of children that we see in our clinic. And delayed puberty can be a significant cause of concern, particularly for boys, but also in girls. So this would be a typical referral. So a 15-year-old boy for assessment of short stature. He's really worried. He's had no pubertal development yet. Now, I just put in a word of caution here. It's surprising how many boys will tell you they've got no pubertal development when they actually have. And it just reinforces the importance of always actually doing a physical assessment. Don't take their word for it. Don't let them point to you on the Tanner chart where they think they are, because that is very rarely accurate. So it's worth spending a little bit of time talking them and explaining about why a genital examination is important in this setting. So delayed puberty affects around 3% of all young people, and it's much more common in boys than girls. The most common cause is constitutional delay of growth and puberty. These children are healthy, they simply have a slower rate of development and usually have a positive family history. So it could be mum or dad, uncles, grandparents. It can also be secondary to chronic illness, to malnutrition, to stress, and to excessive exercise. It's also seen in conditions such as diabetes mellitus, cystic fibrosis, celiac disease, and increasingly eating disorders. It's rarely caused by loss of hormone production, so very rarely we see hypothalamic or other pituitary disorders, and again, rarely ovarian or testicular disorders, but they would fall right down the bottom end of our potential differentials. So this would be the typical history. So this young man was always shorter than average, growing between the 10th and the 25th percentile, was a bit out of keeping with the family. Now more noticeable difference compared to his peers, and looking back, he thinks it was probably around the age of 12 or 13 where the difference in height between him and his friends became quite marked. He's struggling to keep up in sports. He's teased at school because he looks like a kid. And this is really hard because these kids who are developing slowly might look more like they're 10 and 11, and they're in a class with a whole load of young men who look like they're adults. The unremarkable birth and early childhood history, The systems review wasn't concerning. He's had no headaches, no visual disturbances, no change in his sense of smell. So thinking about Kalman syndrome. He was a bit late getting his teeth, and that's a useful clue as well, because these children with slow growth and development are often slow in other areas of development. So someone who was very slow getting his first teeth and then slow losing his baby teeth. He's not on any medicines or anything. Important. His mum is of average height, reached menarche at 13, and she has a history of Hashimoto's thyroiditis. Dad is tall at 185 and recalls being a bit later in his growing than his peers, but also interestingly remembering if his younger brother was still growing at 19 or 20. So there's quite a strong family history here. And that does raise red flags for constitutional delay. So just thinking about target height, for those who are not familiar with it. So a target height is the mother's height and the father's height added together and divided by 2. And then you add 7 centimeters for the boys or subtract 7 centimeters for the girls. And that will give you your mid-parental height. There is a range around that, which is still within the family's genetic potential of about 10 centimeters plus or minus for boys and about 8.5 centimeters plus or minus for girls. The other way to do it would be to plot the adult centiles for mum and dad on the child's chart. So for our case here, his mid-parental height was 181 centimetres plus or minus 10, which is the 65th percentile. So he's very short for the family genetics. So examination, he is 155 centimetres, only the 5th percentile. So remembering that the mid-parental height was 65th. His weight is 39 kilos, so he's not overweight. His height velocity, 5 centimetres a year. It's pretty average for a pre-pubertal child, certainly nothing to suggest a pubertal growth spurt. And we would do body proportions. So in the clinic, we often get them to sit on a box and measure their sitting height. That gives you an impression of their leg length. And we'd look for dysmorphic features, have a quick look in his eyes, make sure his visual fields were normal. Systems examination unremarkable. And in this case, he was G1 with some very early pubic hair development and testes 3 mils bilaterally, so less than Cadbury's mini egg size, so pre-pubertal. And then just a comment on body proportions. Babies have a large body and a big head, and the sitting height to height ratio gives good indications of disproportion. The range changed from high at 0.68 down to 0.52 in adolescence. And you get most of your pre-pubertal in your limbs and most of your pubertal growth in your trunk, which is why the pre-teens and the late developers often look quite gangly, long arms and legs. In the history, you're always looking for a family history of delay. It's almost always there. And also for any chronic illness the child may have been affected by, which could have impacted on their growth or their nutrition and so on. Examination, you're thinking about syndromes. So we've mentioned Klinefelter syndrome before. And this is where you have a child whose testes don't form properly. So they're small, don't produce adequate testosterone. They will often go into puberty, but it can be slow. And the testicular size doesn't increase beyond about 4 or 5 mils. Kalman syndrome, we've also touched on. This is a condition that affects the olfactory nerves and can also affect the pituitary gland, causing a lack of production of the gonadotrophins and an absent sense of smell. You do have to specifically ask for that as well, because kids will not often volunteer it. Anatomical abnormalities, so obviously inspecting the genitalia, is this a child with a variation of sex characteristics or an intersex disorder? Investigations, the ever-present bone age, and we always do that. Again, looking to see whether that is significantly delayed, which would be in keeping with the child's growth pattern. An LH level, is it below 0.4, suggesting they're not yet in puberty? Is the testosterone recordable? You might see the opposite. You might see an extremely high LH level and a low testosterone suggesting resistance. And an inhibin B level can also be a useful indicator of testicular function. Pituitary function screens are always done as part of the initial screen. So an IGF-1, which is an indirect way of measuring growth hormone. As I'm sure you're all aware, growth hormone itself is actually produced mostly at night in little bursts or pulses. So trying to measure random growth hormone in the lab is generally unsuccessful and usually comes back with a low result, which is impossible to interpret. IGF-1s actually maintain a reasonably stable level. So it's a really useful screening tool as an initial test. TSH and T4, you need to do both. A low TSH is not reassuring because central hypothyroidism, you're going to have a low TSH, so you need to know that your TSH and your T4 are normal, to know that there's normal TSH production. And also a prolactin. Prolactinomas can present exactly like this, and we've had a number of children who have presented with prolactins in the tens or even hundreds of thousands and presented with delayed puberty. Extremely easy to treat with cabergoline, so it's very much worth picking up. Chronic illness screen, just thinking about general health, looking for anemia, looking for renal function, liver function. Celiac disease, I've had at least 2 young men in the last few years who were picked up as having celiac disease as a result of assessment of delayed puberty. So this is common, often minimal symptoms in terms of gut symptoms. So worth checking as part of the routine screen, and a CRP would generally be on my list as well. Bone age. So this is back to our patient Nathaniel, who is 15 and essentially has a pre-pubertal pubertal assessment. So his bone age is reported at 11 years, and this is just a picture of a typical 11-year-old male bone age and some of the things that we look at to evaluate it. So lots of our radiology services now have clever AI systems that calculate all of this for us, which is going to make it much easier for us, and hopefully will give us more consistency. But I do still personally like to re-report all the bone ages myself, because there is a lot of inter-observer variation in these, and I do like to make sure that I have seen these. So the rest of our young man's investigations, he had a normal chronic illness screen. Interestingly, he did have strongly positive thyroid peroxidase antibodies, and you'll remember from the history that mum had Hashimoto's thyroiditis. However, his TFTs were in fact normal. And so I would usually counsel the family to say that there is a risk that he will develop hypothyroidism over time, probably about 25%. And I would give them advice around symptoms to watch for hypothyroidism, and maybe recommend thyroid function once a year or earlier if he's concerned about symptoms. His IGF-1, now I've popped in italics there, normal for pubertal stage. Now it's really important to be aware when we measure IGF-1, the reference range varies by gender, but also by pubertal stage. So the reference range is given according to Tanner staging. So if you get a report coming back to you on a 15-year-old, it will probably look quite low until you correct it for Tanner stage, and then it may well be normal. This lad's prolactin was nice and normal. His LH was 0.3, which is in the pre-pubertal range. FSH just up. Testosterone less than 0.4, so again, pre-pubertal. So interpreting the gonadotrophin levels, hypogonadotrophic hypogonadism. So that just means that your gonadotrophins are not working. They're not there, they're low. Now, this can be either just constitutional delay, they just haven't risen yet because they're not at that point in their development yet, or it can be a congenital condition where they're never going to produce these gonadotrophins, such as Kalman syndrome, or it can be acquired through drugs, trauma, irradiation, CNS lesions, and so on. The incidence of congenital hypogonadotrophic hypogonadism is approximately between 1 in 10 and 1 in 100,000 live births, so it's pretty rare, and about 2/3 of them are secondary to Kalman syndrome, so this is not a common situation. Acquired hypogonadic hypogonadism can be caused by a number of different things, but we do also see it in excessive exercise and in eating disorders as well, with this sort of functional picture. Now, the opposite here, hypergonadotrophic hypogonadism. So that's where you've got failure of the testes or ovaries to respond to the gonadotrophins. So your LH and your FSH in this situation are high. Causes of this can be, for example, genetic, Turner syndrome, Klinefelter syndrome, complete androgen insensitivity syndrome, can be autoimmune, galactosemia, defects in the LH receptor, can be a problem in the way testosterone is made in the testes, or it can be caused by radiation or chemotherapy. So a number of different conditions. It is worth noting, though, particularly for the girls, it's not uncommon to not find a cause for primary ovarian failure. And in the majority of those, we don't actually have a defining cause. The biggest challenge for us is differentiating between constitutional delay and hypogonadotrophic hypogonadism. And this is more of an issue for tertiary care. I guess just to kind of inform you that the gold standard, which I always think is quite funny, is the presence or absence of spontaneous puberty by 18, which is all very well, but there's not many boys that would want to wait until 18 before we had a decision on whether or not they were going to go into puberty. So the problem we have is that basal levels, LH, FSH, and even gonadotrophin stimulation tests aren't terribly specific, and there's quite a lot of overlap in the results between these two conditions. We've had a little bit more success using more potent GnRH agonists like buserelin, and we do occasionally do these tests in boys to look and see whether it does look like they're able to produce a good burst of these hormones over time. The other test that's being used more and more in adults is an inhibin B level, which does seem to be quite useful, but it's not been so commonly used in the adolescent group as yet. Management options. So once we've thought through our differential, there's a positive family history. In our case, he's got a normal examination with no red flags. His screening tests are pretty reassuring. So the options we would give to him are, does he want to watch and wait with regular checks on height and weight and Tanner staging? Or does he want us to induce puberty by giving a bit of testosterone? Why treat? Well, testosterone has several effects on many different tissues and systems. And in an ideal setting, we'd want the sex steroid therapy to mimic this physiology and give benefits across a number of different systems. It can help with bone mass accrual, because we know more than 1/3 of bone mass is accrued during puberty. And there's good evidence to suggest that bone mineral density is affected in young men with hypogonadism. And so it's possible it may increase following treatment. Testosterone is important in growth and plays a crucial role in growth regulation. Some studies on adolescents with congenital delay report a near adult height close to predicted adult height. Others suggest these boys might not actually achieve their genetic potential. Several studies reassuringly have reported no significant difference in adult height between those treated and untreated. So that at least tells us that the testosterone induction doesn't adversely affect adult height. And it also is worth noting that delayed treatment may result in abnormal body proportion with very long limbs. And of course, testosterone gives the development of secondary sexual characteristics. It has impacts on metabolism, improving your muscle mass, reducing your fat mass. There is some concern about increased non-alcoholic fatty liver disease in adults, but there does not seem to be associated hepatotoxicity with more modern formulations. There is an erythrogenic effect in adult males who've been on treatment for a long time, but not well reported in teenage boys, and certainly not seen in my practice, and I do screen for this. But psychologically, late pubertal timing can have massive long-lasting effects in young men. And late pubertal maturation can result in a higher risk of depression and substance abuse. So it does have significant impacts. Treatment, well, our options are even less than they were when I first made this slide. We used to have tablets. We can't access that now. So it's basically injections or nothing. And we've got cypionate, or we've got sustanon. I tend to use sustanon because that has a much lower volume. The only time I would not was in someone with a peanut allergy, because I think they use peanut oil in the formulation. Otherwise, that's the best way to go. It's generally given every month, usually starting at a dose of 50 milligrams. These are some studies just showing the outcomes and showing the different regimes people have tried. As you can see, it's a bit of an evidence-free zone, lots of different ways of doing it for lots of different lengths of time. Basically, I follow these boys up 3 monthly, monitor the progression, height, velocity, body comp. I do 3 monthly labs, checking the hemoglobin, liver function and testosterone. I reassess them after 6 months, check their height, Tanner staging, their hormone levels and volumes. And assuming the testicular volume is greater than 6 mils, I would follow them every 6 to 12 months until they've reached a volume of 12 mils or more, suggesting that they're well established in puberty. For those who remain of smaller testicular volume, I would go on to do more investigations looking for less common causes, so genetic testing, Buserelin test, or potentially MRI, and might consider another 3 months treatment at a higher dose. What about the girls? Just briefly, much less common than the boys, 10 times less frequent. Not sure why. Is there an increased tolerance for short stature in girls versus boys? Or there might be specific considerations. Remember, the girls do tend to start puberty earlier and grow at an earlier stage. Assessment, thinking about family history, really important to look for any evidence of eating disorders, excessive exercising, malabsorption. Anosmia in examination, Kalman syndrome does obviously happen in girls. Syndromic features, by far and away the most common is Turner syndrome. There are a significant number of Turner syndrome girls who present in adolescence with primary amenorrhea or pubertal failure. And then other anatomical abnormalities, absence of the uterus, or intersex variations. Investigations again, chronic illness screen, pituitary function, gonadotrophins, karyotype, particularly to exclude Turner's, a bone age x-ray, and I would always do an ultrasound of a pelvis, look for the presence of the uterus and its size and shape, and also the ovarian appearance. Again, touched on this already with the interpretation of the gonadotrophins with the boys. Treatment for girls, you do need to be really careful here. There's better evidence for transdermal than oral estrogen. Oral estrogen is much more likely to advance the bone age. We'd never treat for more than a year, and we go very, very small dosing. So tiny little chopped up 1/8 of a 25 microgram estradiol patch is probably as high as we'd go with that. And that is very fiddly. Remember, it stops your growth if you go too long. The aim is to initiate growth phase and early breast development. You need to start with really low dose, because the danger is you can end up with this, which is called tuberous breast deformity, if you go for big doses too quickly. And that has to be surgically corrected. You need to monitor closely to avoid overtreating. Don't treat for more than 12 months, and don't start the pill immediately, because it really accelerates bone maturity and reduces final height. I usually reassess these girls after about 12 months. And if they have no further progression once I've stopped treatment, then further investigations are indicated. So to summarise, for delay, pubertal delay is common. There's usually a positive family history. It's more likely in healthy boys than girls, maybe due to chronic illness. Tanner stage and testicular volume predicts adult height. And induction of puberty is simple and cheap. And that's me. Thank you very much. And I am very happy to take questions.
Thank you, Fran. That was a lot to cover in a short space of time. Cool. So we've got lots of good questions coming through, Fran. So we had a question around the bone age, Fran, which you mentioned many times and showed us that picture of the hand. Can you tell us a little bit about that? Because it's not a test that we'd often kind of see or order in general practice. Is it just the hand that gets x-rayed, and how might we go about accessing that test in the community?
Yep, so what we measure, what we look at is the left hand. Now this is because for most people, the left hand is the non-dominant hand. And so it's less likely to be muscled, which can change the appearance. And basically what you request is a left wrist and hand, and you're really just looking at this view, AP view. And then what the radiologist will do is they look at an atlas, which has got examples of children's bone ages all the way through life, from infancy right up to 18 or 19. And it's basically a direct comparison. So the AI is very clever, and they do all these clever measurements and, measure the shape and the angles of all the bones. But for most of us, it's more pattern recognition, looking at the different appearances of the bones, how wide the gap is, how the epiphysis, where the growth plate is, and how mature the bones look. The radiologists will always report the bone age, and you can request a standard deviation as well. So the standard deviation just means how much variation is acceptable at different ages, and that does differ a lot depending on the age of the child. So that's worth requesting. So asking for a left wrist and hand x-ray for bone age, and then you can put please report standard deviation, and that will give you all of that information.
Great, yeah, because a lot of what you're saying is, is it normal, is it not, kind of dependent on the standard deviation. So that's a good tip to make sure we ask for that. We have a number of questions around testicular volume. That was going to be one of my questions too. Once I think one of the endocrinologists asked me about it, and I thought, oh God, I've never been taught this in med school, how to measure that. So you mentioned the Cadbury egg, the mini egg is about 4 mils. Any other tips on estimating testicular volume, Fran?
Yeah, so obviously not everyone's going to have an orchidometer. You might have seen these. They basically look like a string of beads with increasing sizes. And so anything below the Cadbury's mini egg is prepubertal, above is pubertal. Beyond that, it's a little bit subjective. So I think primarily the utility of them in primary care would be around, are they in puberty? Is that volume greater than 4 or less than 4? If it's sitting around the 4 mark in a boy who is quite clearly well established in puberty, that would be one of our red flags. So this is where you would start to wonder about a condition called Klinefelter's, where the testes just don't enlarge and they don't produce enough testosterone. So this might be a boy who looks reasonably well virilized, but the testes are quite small.
Okay, great. That's good to have that 4 as kind of a line in the sand. Now, isolated body odor in a child, like you said, under 8 for girls, under 9 for boys, is that in and of itself a concern if there's no other symptoms?
It really isn't. We actually I've had quite a few referrals with this exact problem, and I have never found anything ever. It always causes lots of anxiety. And I think when in doubt, you could do the androgen profile, do the bloods, and I've never picked up an abnormality. Sometimes it then progresses into a little bit of pubic hair development, and these kids that do end up having premature adrenarche. It often runs in families. I've had a couple of sibling pairs where they've developed body odor at between 4 and 5 years of age, and it's never come to anything. So in and of itself, the chances of it being pathological are really, really small. If the family are really worried, you could do the androgens for reassurance and then just counsel on what symptoms to watch for. So particularly pubic hair development, a rapid growth spurt, or changes in the skin, so acne or oiliness.
Cool. With regards to the investigations, Fran, so you mentioned a whole range depending on what they're presenting with. Some of them we might be more familiar with ordering in primary care, like your testosterone and your LH-FSH. Some of them are a lot more kind of specialized. Now, when the health pathway's out, this will answer, I guess, this, which would be a great reference. But out of those in general, what ones do you expect us to order before we write to you, versus wait for you guys to see or assess the child to tell us, hey, order these things? It's a bit tricky without a clinical case, but
it is. So for the early pubic hair development, I think it is worth doing those androgens, because if they're all normal, then this is almost certainly benign adrenarche, and there's really nothing else that needs to be done. So the child doesn't necessarily even need to be seen in hospital. So doing the 17-OHP, which rules out the congenital adrenal hyperplasia, checking the DHEAS, the androstenedione on the testosterone, that basically rules out tumours, any nasty malignancies, and at that point, a mild increase in DHEAS is what we commonly see. So even doing those things and then putting in the referral for advice would be totally appropriate. We're very happy to say, yep, that all looks great. Here's what, just see them again in 6 months to check their growth and their development. That might be all you need to do. And again, I will put all these in the health pathway and make sure it's really, really clear on the timing of the samples. The biggest thing is making sure it's a morning sample, because 17 OHPs done in the afternoon are unfortunately uninterpretable, and we're never very popular when we ask the family to go back and do it again.
Okay, wonderful. Now, the timing of the LH and FSH in adults and women, we usually time that with their menstrual cycle. For children, is there things we should be mindful of with the timing of those?
No.
So
No.
random samples, okay?
Random samples, absolutely fine. Yep.
Okay, great.
We're primarily doing these in people with no pubertal development or very early, so it doesn't matter.
Okay. Now, back to symptoms. So isolated acne in a child outside of other symptoms, how concerned should we be about that?
Again, this is very rarely any underlying endocrine issue. What this most likely is someone who's got just increased sensitivity to the low levels of androgen you get early on in adrenarche. So adrenarche is the kind of natural increase in androgen rise that we get kind of around 8 or 9, something like that, as we start entering towards puberty. It often runs in families. So there's a family history with a parent who has a very similar recall of severe acne in childhood or adolescence. Again, acne on its own, almost never underlying endocrine issue, but obviously checking for, increased height velocity, checking for any evidence of pubic hair, asking about other physical changes are really important, but almost never finding any pathology.
With regards to height, Fran, so you mentioned, say, after you'd assessed and if you just wanted to monitor, maybe do it 6 monthly. When you're, first of all, working this up and trying to find out what's going on, how often should we be checking their height if we don't have a lot of data already? I guess sometimes in primary care children, if they're well, we might not see them for a couple of years and we don't have height data over time.
Yeah, no, that's absolutely right. I mean, it's not unusual as well when people come into the clinic and they'll say, oh, we've measured them against the wall a couple of times in the last few years, and that's about all they've got. So that's when mid-parental height comes in really handy. So looking at what you'd expect this child to be growing at based on the family height. And if they are really tall, so if you've got a child who's way above what you'd expect for when you calculate the mid-parental height, that can be a red flag there. And then probably kind of 6 monthly, looking at speed of growth. It's very, children don't grow steadily, they grow in little fits and bursts. So if you measure their height too frequently, you can sometimes get overly concerned because there doesn't seem to be much change or there's too much change. But measuring over about 6 months gives you a much more realistic idea of how they're tracking.
Oh, that's really helpful and practical. Thank you, Fran. And can you tell us a little bit more about height velocity in terms of the significance and how we would calculate that?
Yep. Okay. So height velocity charts are available. So there is a big variation, absolutely. I don't think I've got one handy to show you, but so children start off life growing really quickly. So if you look at the speed of growth chart, it's the height velocity starts really high, falls away over childhood, hits the lowest point of around 5 centimeters a year, usually just before they enter puberty, and then increases up again as they go through their pubertal growth spurt. So a speed of growth by late childhood of around 5 or 6 centimeters a year would be very normal. Getting up to 7, 8, 9 centimeters would be starting to get much higher than we would expect, and that could suggest early pubertal development. There's lots of standardized growth charts around with height velocity standards on them. I use my growth charts in my private practice, which is a really good one. But otherwise, there are the old paper charts we used to have that had the height velocity charts. They're still available online if you look on the ANSPED website. So that's the Australia New Zealand Society for Paediatric Endocrinology and Diabetes. They have a whole load of resources there and growth charts for people to access for free.
Okay, great. So outside of just the centile, the velocity can help us to know whether it's pathological or not, what they're presenting with. Okay, great. We've got a question around examining a child when they're not there with their biological parent or I guess their main caregiver. Sometimes other people might bring them in if it's an auntie or a friend or something like that. And obviously with these examinations, we want to do a full examination, like you say, and that's sensitive. So how do you suggest we approach that, Fran?
Yeah, and it's sometimes surprising that people come in with this kind of history and then don't seem to expect you to want to examine the child. So yeah, I mean, I think you obviously have to be sensitive in the situation, and if you feel like this is not something that we can assess without mum and dad present, then just don't even start. I would explain to the parent, the caregiver and the child what we're going to do. Explain that this is part of a normal examination, make sure they understand, and make sure you have a chaperone in the room with you at all times as well. I never do any internal examinations in little girls. You just do an external inspection, usually just of the vulva. So for things like clitoromegaly or looking at the estrogenization of the mucosa. But otherwise, I wouldn't be doing anything in any more detail than that. It is really tempting just to say, here's a picture. Where do you think you are on this? But it's not very accurate. Kids tend to just it's all very embarrassing. So they just kind of point at a picture and hope you'll stop asking them these embarrassing questions. So it is really important, I think, if you can, to get a proper inspection. And it might mean bringing them back another day with a caregiver who they feel more comfortable with, or going away and having a chat with mum and dad about what's going to happen, coming back on another day and not rushing it.
Now, with central versus peripheral precocious puberty, Fran, how important is it that us in primary care know the difference or can differentiate that or can look into that?
Yeah, so I think with both of those, you're going to have quite abnormal biochemistry when you do your results. So this would be typically the little girl who presents with progressive breast development. Their bone age is going to be advanced. So for someone with central precocious puberty, you will have a LH and FSH level that is in the normal range and an estrogen level that's recordable. For someone who has peripheral precocious puberty, you might have a high estrogen level, but the gonadotrophins will be quite suppressed. It doesn't really, the exact diagnosis doesn't really matter. In that situation, you've got abnormal biochemistry in a young child who's progressing through puberty. I think just recognizing that there is an abnormality here, that the timing is out, is a reason enough to refer through.
Okay, that's great. Now, initially, Fran, you mentioned some health supplements, and I guess someone's asking here around supplements that, you know, boys, even teenage boys might take for the gym, or steroid use and things like that. Just any kind of general comments or thoughts on what we should be mindful of with those?
I mean, things like, you know, protein powders and things like that, other than that probably doesn't actually help you build up any muscle, is not going to be particularly harmful. It's more that some of the things that people get in the gym, so this is the anabolic steroids basically, and the particular case I'm thinking of, it was a parent who was using them and who was giving some of it to the young child to help them get strong, without really thinking through the consequences. So, but there's obviously other ways you can be exposed to these things. It could be a parent who's using testosterone gel, something like that, that could be transferred to the child. But other supplements, so things, high use of things like lavender oil or tea tree oil. So essential oils, you know, the oil burners using them all the time in the house, potentially can cause a little bit of breast development in some children.
Now, Fran, outside of the upcoming health pathway, which we're all very much anticipating after this talk, is there any already available kind of Starship guidance or good resources for primary care that you're aware of?
Yeah, absolutely. So I can send through some links. There's some great websites. The ANSPED website has a little booklet called Puberty and Its Problems. It's this fantastic resource that I can send through to you. There's also a British website called You and Your Hormones that's got some amazing resources. It's divided into kind of what the organ systems are, what the conditions are, what the treatments are, and it's kind of set at different levels. So health professionals, it's a great parent and patient resource as well. So people can kind of click through and learn about the different organ systems if they're interested. And they're pitched at a really nice, clear level as well.
Okay, great. Awesome. I think we've had a lot of comments saying it's been a great presentation and there's lots to mull over there. So I think my brain's certainly full for the evening. Now, Fran, thank you so much for your time. Really appreciate it. Hope for the audience that we answered most of your questions. Cool. Awesome. Thank you, everyone, and good night.
Thank you. Good night.